For this protocol in the Mercy 2019 guidelines, we talked about hypothermia and frostbite. For our assessment, the patient assessment should begin with attention to the primary survey, looking for evidence of circulatory compromise and ensuring effective respirations. The patient suffering from moderate or severe hypothermia may have severe alterations in vital signs, including weak and extremely slow pulses, profound hypotension, and decreased respirations. The rescuer may need to evaluate the hypothermic patient for longer than the normothermic patient. Along with standard sample type history, additional patient history should include A. Attention to any associated injury or illness, B. Duration of cold exposure, C. Ambient temperature, D. Treatments initiated before EMS arrival. There are several means to categorize the severity of hypothermia based on either core body temperature readings or clinical evaluations. For mild normal body temperature, 95 to 89.8 degrees Fahrenheit. For moderate hypothermia, 89.7 to 82.5 degrees Fahrenheit. Severe, 82.4 to 75.2 degrees Fahrenheit. Profound is less than 75.2 degrees Fahrenheit. Most important is the patient's clinical presentation and the signs or symptoms the patient is experiencing. For mild, vital signs may not be depressed, normal mental status, shivering is preserved, and body maintains the ability to control its temperature. For moderate and severe hypothermia, there is progressive bradycardia, hypotension, decreased respirations, alterations in mental status with eventual coma, shivering will be lost in moderate hypothermia, and general slowing of bodily functions. The body loses the ability to thermoregulate. Treatment and interventions for the hypothermia patient is first, maintain patient and rescuer safety. 2, manage the airway per protocol. And 3, in the mild hypothermia patient, we have remove the patient from the environment and prevent further heat loss by removing wet clothes and drying skin. Insulate from the ground, shelter the patient from wind and wet conditions, and insulate the patient with dry clothing or a hypothermia wrap blanket. Cover the patient with a vapor barrier, and if available, move the patient to a warm environment. Next, maintain SpO2 of greater than 93%. Consider field rewarming methods. Consider IV access. If alterations in mental status, measure blood glucose and treat as indicated per protocol, and assess for other causes of alterations of mentation. For moderate and severe hypothermia, start with perform the ABCs, manage the airway as needed, and note care must be taken not to hyperventilate the patient, as hypocarbia may reduce the threshold for VFib in the cold patient. Next, C, prevent further heat loss by removing the patient from the environment and removing wet clothes and drying skin. Insulate from the ground, shelter the patient from wind and wet conditions, and insulate the patient with dry clothing or a hypothermia wrap blanket. Cover the patient with a vapor barrier, and if available, move the patient to a warm environment. D, initiate field rewarming methods. Chemical heat sources should never be applied directly to the patient's skin. E, handle the patient gently. Attempt to keep the patient in the horizontal position, especially limiting motion of the extremities to avoid increasing return of cold blood to the heart. Once in a warm environment, clothing should be cut off, rather than removed by manipulating the extremities. Move the patient only when necessary, such as to remove the patient from the elements. Next, apply the cardiac monitor, or AED. G, establish IV and provide a normal saline bolus as indicated, warm fluid if available. If alterations in mental status, measure blood glucose and treat per protocol there. Assess for other causes of alterations of mentation. Transport as soon as possible to a hospital capable of resuscitation. If cardiac arrest develops, consider transport to a center capable of extracorporeal circulation or ECMO or cardiopulmonary bypass. Warm the patient compartment of the ambulance. For frostbite, if the patient has evidence of frostbite and ambulation/travel is necessary for evacuation or safety, avoid rewarming of extremities until definitive treatment is possible. Additive injury occurs when the area of frostbite is warmed, then inadvertently refrozen. Only initiate rewarming if refreezing is absolutely preventable. Rewarm using contact with other non-affected body surfaces. Do not rub or cause physical trauma. Treat per pain management protocol. Thanks.